Welcome to the Confident Nurse Podcast, your shortcut to being genuinely well informed, packed with surprising facts and tools you can use on your shift at the bedside. Today, we're diving headfirst into a world where every single second is a high stakes gamble, where life and death really hang in the balance, and where some truly incredible skills are put to the ultimate test.
It's a stark reality, isn't it? We're talking about trauma, which is quite shockingly the leading cause of death for individuals under 45 worldwide. And what's really unsettling is when you dig into the data that a significant portion of these deaths are, in fact, preventable.
Yeah, that word preventable really cuts through, doesn't it? It immediately conjures images of a chaotic yet somehow meticulously organized emergency room or trauma bay. It's a place where swift, decisive action isn't just a goal, but an absolute necessity. And right at the very heart of that controlled chaos, orchestrating those rapid, life saving interventions are highly trained, incredibly skilled nurses.
Yeah. And our mission with the Confident Nurse today is to give you an exclusive look, a real shortcut into the intensive evidence based training these nurses receive. I'm Andrea, an ICU trauma nurse for nearly 2 decades, here to share the insights I wish I'd had earlier in my career. And with me is Nate, who'll be asking the key questions you'll want to know. Specifically, we're focusing on how nurses manage some of the most critical injuries, those affecting the thoracic or chest and abdominal regions of the body. This isn't just academic theory, it's the practical, real world knowledge that turns nurses into true lifesavers in those crucial moments.
To make this as authentic as possible, our insights today come directly from an advanced nursing course in thoracic and abdominal trauma management. You're essentially getting a front row seat to the kind of rigorous education that empowers these professionals. It's like peeking into their specialized arsenal for saving lives.
Precisely. And for you, our listener, it offers a profound appreciation for the sheer resilience of the human body, the astonishing speed and precision required in critical care. Here we can see the immense dedication of the healthcare workers protecting patients when they are at their most vulnerable.
So let's unpack this journey then. We're going to begin by laying out the foundational pillars of trauma care, how nurses assess and resuscitate patients in those precious golden minutes. Then we'll take a look into the specific injury patterns within the chest and abdomen, understanding how they're diagnosed and managed. We'll look at the tailored rapid fire interventions nurses perform. And finally, connect it all to the long term ripple effects of trauma and the undeniable power of teamwork. This can be an intense but, I think, incredibly enlightening exploration into what it truly takes to save a life.
All right, let's kick things off with something that often gets overlooked, maybe, but is utterly fundamental: trauma epidemiology.
When we talk about trauma, it's not just random accidents, is it? It's a massive, pervasive public health challenge. What's the biggest takeaway you think from looking at the patterns of who gets injured and why?
That's a powerful starting point because while it feels random, the data tells a story, a really clear story, actually. Trauma, particularly the severe thoracic and abdominal injuries we're discussing, contribute substantially to global morbidity and mortality. And as you highlighted, in the United States, it is the leading cause of death for individuals under the age of 45. The truly astonishing insight here is that phrase you used earlier: preventable death. Many of these fatalities aren't inevitable. They could be avoided with timely, structured assessment and intervention. It's not just about getting a patient to the hospital, it's about the speed and quality of care in those crucial moments after the injury occurs, you know?
So, if preventable deaths are the core insight, that brings to mind the trauma chain of survival. Sounds like an incredibly important concept. Could you walk us through what that chain entails? Like what makes each link so critical, especially for nurses?
Yeah, the trauma chain of survival is exactly what it sounds like: a sequence of critical steps where each link must hold strong, absolutely has to. It emphasizes rapid recognition of injury, immediate and effective early resuscitation, and then seamless coordination with surgical teams for definitive care. Nurses are truly at the forefront of this chain, driving the initial assessments and interventions. They are the ones who can often make the critical difference in the very first minutes.
That makes sense. And the epidemiology you mentioned, that certain demographics are more affected. What does that tell us about the broader impact of trauma?
Well, the epidemiological patterns reveal some sobering truths. Young adult males, for example, are disproportionately affected by both blunt and penetrating trauma. This is often linked to factors like risk taking behaviors, maybe occupational hazards, or even interpersonal violence. So, understanding that helps us look at preventative measures, but it's not exclusively a young male issue, not at all. Older adults are also a highly vulnerable group, particularly from falls. What's fascinating and often missed here is that age related physiological changes like decreased organ reserve, more fragile bones, or thinner skin can make what seems like a minor fall incredibly severe for an older patient. It increases their risk of severe injury and mortality significantly. It really highlights the broad impact of trauma and the hugely varied patient profiles nurses encounter daily. It's it's never a one size fits all approach.
Now, that really drives home how much of this is interconnected with our daily lives and societal factors, just everyday risks. Okay, moving on to the how, the mechanisms of injury, how the trauma happened. This is crucial, isn't it? This is where nurses start to read the body story.
Absolutely. Understanding the mechanism of injury is one of the foundational pieces of information a nurse needs to understand immediately upon a patient's arrival. We broadly differentiate between blunt trauma and penetrating trauma. Blunt trauma typically results from forces like motor vehicle collisions, high falls, or crush injuries where the body impacts something without the skin being broken. Penetrating trauma, on the other hand, comes from objects that pierce the skin, such as gunshot wounds or stabbings. Pretty straightforward distinction there.
And it's not just what caused the injury, but why that distinction is so incredibly critical for a nurse's immediate assessment. What's the core insight there? Why does it matter so much?
Yeah. The core insight here is that these two types of trauma present fundamentally different challenges, completely different. Blunt trauma often hides severe internal damage. The external appearance can be deceptively benign. You might see minimal visible signs of injury on the surface, even while vital internal organs are suffering tremendous silent damage. This hidden nature makes assessment particularly challenging and demands exceptional vigilance from nurses. Think of a high speed car crash. A patient might look relatively intact externally, but the internal deceleration forces can, well, tear organs or cause massive internal bleeding. Abdominal tenderness after such an event, for example, would immediately demand an evaluation for solid organ injury because it's a huge red flag for hidden bleeding.
So, blunt trauma is like a puzzle with invisible pieces, whereas penetrating trauma, like a stab wound, usually has a very obvious entry point. But even then, the internal damage can be incredibly unpredictable, right?
Exactly. With penetrating trauma, while the entry wound is often visible, the path the object took internally can be incredibly unpredictable. It can affect multiple organ systems in ways you might not expect. A bullet, for instance, can ricochet or tumble, causing damage far, far from a straight line. This often necessitates immediate surgical exploration. You just have to go look. So, this mechanism based thinking is the first crucial step in prioritizing care. It guides the urgency and focus of the entire assessment process. It changes everything for care providers.
That makes so much sense. Okay, let's talk about the primary survey, often called the golden minute of life saving decisions using the ABCDE approach. This is the rapid fire assessment designed to find and fix immediately life threatening conditions. It's about speed over thoroughness here, right?
Right,
Like really fast.
you've got it. The primary survey is systematic but incredibly rapid. The sequence of A, B, C, D, E is vital because hypoxia, a lack of oxygen to the body's tissues, is a leading and often preventable cause of early trauma death. So we start with A for airway, always. Nurses immediately assess for any obstruction, listen for stridor or gurgling sounds, check for facial trauma or altered consciousness, which can compromise airway reflexes. Interventions here are immediate, positioning the patient to open the airway, suctioning to clear secretions, and preparing for advanced airways like intubation if needed. Securing that airway early is non negotiable. It's literally the first step to ensuring oxygen can reach the brain and vital organs.
And then once the airways open, it's straight into B for breathing.
Yes, Here, nurses evaluate chest expansion, listen to breath sounds, check oxygen saturation levels. They're looking for immediately life threatening thoracic injuries. For instance, a tension pneumothorax is a critical one. That's where air gets trapped in the chest cavity, building immense pressure. It can present with absent breath sounds on one side, a deviated trachea pushing the windpipe to the opposite side, and a dangerously dropping blood pressure leading to cardiovascular collapse. It's bad news. Or a hemothorax where blood fills the chest cavity, or even a flail chest. That's where multiple rib fractures cause a section of the chest wall to move paradoxically inward when the patient tries to breathe in and outward when they breathe out, severely impairing ventilation.
So, if I'm understanding correctly, a flail chest basically means a part of the chest wall isn't moving in sync with the rest, like a broken section of a pump, making it incredibly hard to get a good breath in.
Exactly. A fantastic analogy. That's precisely it. It compromises the mechanics of breathing completely. For breathing issues, interventions can range from administering high flow oxygen to assisting the provider with needle decompression for a tension pneumothorax or preparing for a chest tube insertion. Prompt recognition here is absolutely critical to preventing rapid deterioration and saving a patient's life. You have to be quick.
That sounds like a lot to do and fast.
It truly is.
What comes after breathing?
Next is C for circulation and hemorrhage control. This is paramount as uncontrolled bleeding or hemorrhage is the leading preventable cause of death in trauma. Can't stress that enough. Nurses rapidly assess for pulses, check skin color and temperature, and gauge capillary refill to understand how well blood is circulating. They establish large bore IVs, typically two of them, and initiate fluid resuscitation. For significant bleeding, early administration of blood products is crucial, often following a balanced transfusion strategy with a 1:1:1 ratio of plasma, platelets, and red blood cells.
And why is that 1 to 1 to 1 ratio so important instead of just giving lots of red blood cells?
That's a great question, and it's a critical shift in trauma care. It really is. The insight here is that we're not just replacing lost oxygen carrying capacity with red cells. We're essentially trying to mimic whole blood as closely as possible. Plasma contains crucial clotting factors, and platelets are essential for forming clots. Without replacing these, you can actually worsen the patient's ability to stop bleeding, creating a vicious cycle. Not good. So it's about giving the body everything it needs to stop hemorrhaging. External bleeding is controlled with direct pressure, pressure dressings, or tourniquets if necessary. Rapid control of bleeding is truly paramount.
Then we quickly move to D for disability and E for exposure. What do those involve?
Right. For D for disability, it's a quick neurological assessment, typically using the Glasgow Coma Scale, GCS, which gives us a baseline of their conscious level. Very quick check. And E, exposure means fully visualizing the patient by cutting off all clothing to find any hidden injuries. You have to see everything. This must be done while simultaneously maintaining the patient's warmth to prevent hypothermia, which can actually worsen bleeding. So, expose but keep warm. It's a systematic race against time, a truly coordinated dance in the trauma bay where nurses are constantly monitoring, communicating, and preparing for the next urgent intervention.
That's why every second genuinely counts, right? Okay, so once those immediate life threats are addressed, it's time for the secondary survey. This is where the team really digs deeper for those hidden dangers right after the initial rush.
Exactly. The secondary survey is a comprehensive head to toe physical examination, a full look. Its purpose is to catch those less obvious injuries that might have been missed in the initial chaotic rush of the primary survey. A critical component here is gathering a focused patient history using the ample mnemonic, allergies, medications, past medical history, last meal, and events surrounding the injury. This provides crucial context for decision making. You need that background.
And nurses play a central role in gathering that ample history, which makes so much sense, especially since they're often the ones consistently at the bedside, right? This stage also brings in those vital diagnostic tools like x rays, CT scans, and the focus assessment with sonography and trauma or fast exam.
Right. And these initial assessments set the stage for understanding specific injury patterns. To help objectively assess injury severity and guide triage in such chaotic environments, we also use trauma scoring systems. Tools like the GCS, the Revised Trauma Score, RTS, which incorporates respiratory rate, systolic blood pressure, and GCS, and the Injury Severity Score, ISS, provide objective frameworks.
So these scores sound incredibly useful for predicting outcomes and prioritizing care. It's almost like a quick universal language for a patient's condition, a shorthand.
They are, and they're invaluable for research and triage too. But it's crucial to remember that these scores should never replace clinical judgment. Never. A patient might have seemingly stable scores, yet show subtle, concerning signs of decompensation that only an experienced eye can catch. Subtle changes matter. So, the core insight here is that while these tools provide essential objective data, they're always interpreted through the lens of ongoing vigilant clinical assessment. This is how complex medical decisions are quickly standardized, yet remain deeply patient centric, always integrating objective data with a nuanced observation.
Okay, let's take a closer look into the anatomy then and the specific injury patterns that make trauma to these regions so dangerous. First, thoracic trauma of the chest. It's truly home to so many vital organs, isn't it? Makes it incredibly vulnerable.
Yes, it is. The chest cavity houses the lungs, the heart, the great vessels like the aorta and the diaphragm. So, injuries here can compromise both breathing and circulation with terrifying speed. Terrifying. Thoracic trauma accounts for nearly a quarter of all trauma related deaths, precisely because of this density of vital structures. Let's break it down by structure because each presents its own unique challenges.
Makes sense. Starting with the bony thorax, the ribs, sternum, and clavicle, what happens when these break? Seems painful, but what's the real danger?
Well, fractures to these bones can directly impair breathing due to pain and instability. Obviously, painful. Yes, but multiple rib fractures, especially in contiguous ribs, can lead to what's called a flail chest. We touched on this earlier, but it's such a vivid example of impaired ventilation. It's where a segment of the chest wall paradoxically moves inward with inspiration and outward with expiration, just flops around. This completely disrupts normal breathing mechanics and severely impairs oxygen exchange. Sternal or clavicular fractures often indicate high energy trauma, signaling that there could be more serious underlying cardiac or pulmonary injuries that aren't immediately visible. Nurses are keenly aware that what's visible on the outside, a broken rib, can hide much more significant, potentially life threatening internal damage. The clinical pearl here is that bony injuries are rarely the only concern. They're often indicators of deeper issues. Always look deeper.
And then the pulmonary structures themselves, the lungs and pleura, these are highly susceptible to direct impact, aren't they? Being sort of delicate.
They are very susceptible. They're essentially sacs of air and blood vessels, so impact can do a lot of damage. Common injuries include pneumothorax, which is air in the pleural space outside the lung, causing the lung to collapse. Simple collapse. Its life threatening cousin, tension pneumothorax, is where that air gets trapped, building immense pressure. This pressure can cause the trachea to deviate or shift away from the affected side, dangerously drop blood pressure, and lead to cardiovascular collapse. It's an immediate, dire emergency. Then there's hemothorax, where blood fills the pleural space. If it's a massive hemothorax, meaning more than 1,500 milliliters of blood initially drains from the chest tube, or more than 200 milliliters per hour ongoing, it demands urgent surgical intervention because the patient is losing so much blood so quickly they're bleeding out internally. And finally, pulmonary contusions, which are essentially lung bruises or bleeding within the lung tissue. These can silently worsen over 24 to 48 hours, leading to significant respiratory compromise. Sneaky problem.
That's a lot of things that can go wrong just with breathing. But the chest also houses the cardiac and great vessels. These sound like the most immediately fatal injuries, the really scary ones.
They are. Injuries to the heart and great vessels are less common, but when they occur, they are often immediately fatal right there on scene. A critical one for nurses to recognize is cardiac tamponade. That's where blood accumulates in the pericardial sac, the tough membrane surrounding the heart. This squeezes the heart, preventing it from filling properly, leading to a type of shock called obstructive shock. The classic signs are known as Beck's triad: low blood pressure or hypotension, muffled heart sounds because of the fluid around the heart, and distended jugular veins in the neck. However, these signs aren't always complete or immediately obvious, making vigilant monitoring crucial. You might not see all three.
So the core insight here is that the heart can essentially be squeezed shut from the outside, even if it's perfectly healthy otherwise, which is a truly terrifying and rapid way to lose a patient.
Absolutely. It's like a vice tightening around the heart. Exactly that. Then there's myocardial contusion or a bruised heart, which can actually mimic a heart attack with chest pain and arrhythmias, making diagnosis tricky. Confusing picture. Injuries to the great vessels like the aorta or vena cava are frequently fatal on scene due to massive rapid blood loss. Survivors often present with unequal pulses and severe hypotension. The sheer density of vital organs in the chest truly makes thoracic trauma an incredibly high stakes emergency where even minor external signs can mask severe internal damage.
Okay, let's shift to the abdomen. This feels like an even more hidden battlefield. I imagine injuries here often have subtle or delayed signs, like you mentioned.
It's often called the black box of trauma for a very good reason. Yeah. The abdomen houses a staggering array of organ systems: gastrointestinal, vascular, urinary, and reproductive, just packed in there. This makes injuries here incredibly varied, complex, and yes, signs can be frustratingly subtle or delayed, adding immense challenge to diagnosis. You learn quickly in this job never to judge a book by its cover, especially when that book is a human body after a high speed impact.
So let's talk about the solid organs first: liver, spleen, and kidneys. How are these different from the others? What makes them solid?
These are highly vascular, meaning they're rich in blood supply and therefore at incredibly high risk of massive internal hemorrhage when injured. Splenic rupture is actually the most frequent abdominal organ injury from blunt trauma and a leading cause of preventable trauma death. Very common, very dangerous. It often presents with pain in the left upper quadrant of the abdomen and referred pain to the left shoulder, known as Kerr's sign, a classic but not always present symptom. That shoulder tip pain is key. Liver lacerations, typically causing pain in the right upper quadrant, can also lead to substantial bleeding. The liver's huge, holds a lot of blood. Renal trauma, often from direct impacts to the flank area, might present with blood in the urine or hematuria. The immediate life threatening concern here is rapid blood loss: bleeding, bleeding, bleeding.
And then there are the hollow viscera, the stomach, intestines, and bladder. These are different, right?
Yes, they are affected in a different way.
Less about immediate bleeding, more about something else.
A critical nursing principle here is to never remove impaled objects. Cannot stress that enough. Don't touch it. That object, whether it's a knife or a piece of metal, might actually be tamponating, essentially plugging a major bleed. Removing it could unleash catastrophic hemorrhage, instantly fatal sometimes. Instead, nurses meticulously stabilize the object in place, control any external bleeding around it, and prepare for rapid surgical exploration. Assessing the likely trajectory of the object is also key to anticipating which organs might be affected, allowing the team to prepare for specific surgical needs. Think about where it might have gone, so it's not just trauma, it's what kind of trauma, and that changes everything for care providers, demanding different skills and priorities.
That makes so much sense. Stabilize, don't pull. Okay, so for nursing management of thoracic trauma, what are the critical life-saving interventions they lead on? Breathing is so fundamental, I imagine is paramount.
It truly is the breath of life, and nurses are central to every aspect of it: stabilization, managing chest tubes, implementing ventilation strategies, and recognizing complications. Huge nursing role here. Let's talk about chest tube management. Nurses prepare the patient and gather supplies for insertion by the provider, but their role extends far beyond that initial setup. They meticulously monitor the system for bubbling and fluctuation in the water seal chamber, which confirms the tube is patent and functioning, and ensures strict sterility to prevent infection. Got to watch that closely. They also meticulously document the output, both its volume and character. How much blood? What color? The clinical pearl here is that chest tube patency is non negotiable for survival. If it clots off or kinks, you're back in trouble fast. Any dislodgement, kinks in the tubing, or persistent air leaks can rapidly lead to deterioration or even another tension pneumothorax.
So much to watch with just one tube. And how about ventilation strategies? What does a nurse actively manage there, beyond just putting on an oxygen mask?
It's more complex. For hypoxemia, high flow oxygen titrated to maintain oxygen saturation above 94% is usually initiated immediately. That's step one. Nurses are constantly monitoring the effectiveness of these strategies via breath sounds, chest rise, and arterial blood gases, ABGs, which tell us the patient's oxygen and carbon dioxide levels. Are we actually improving things? In severe cases like a flail chest or acute respiratory distress syndrome, ARDS mechanical ventilation may be required, and nurses play a critical role in managing that equipment and patient response alongside respiratory therapy. A massive nursing priority is the rapid recognition of signs of attention, pneumothorax, absent breath sounds, respiratory distress, tracheal deviation, and hypotension. Recognizing that pattern fast. The priority then is immediate notification to the provider, preparing for needle decompression and ensuring adequate oxygenation. Get ready to act for a massive hemothorax, which, as we discussed, is more than 1,500 milliliters of blood initially, or more than 200 milliliters per hour of ongoing blood loss. Surgical intervention is highly likely to be required. That much blood means OR time. The sheer mechanics of breathing can be incredibly fragile, and nurses are often the engineers constantly monitoring, anticipating, and if needed, actively participating in repairing those critical functions.
Fascinating. Now, moving to nursing management of abdominal trauma. This seems like an even more intense race against the clock for internal bleeding, especially since so much of it can be hidden. That black box again,
It absolutely is a race against time. Nurses lead the charge in hemodynamic stabilization, utilizing diagnostic tools and implementing meticulous postoperative monitoring. Hemodynamic stabilization begins with early recognition of shock tachycardia, pallor, cool extremities, subtle drops in blood pressure, and altered mental status. Catching it early is key. They establish those two large bore IVs immediately and initiate fluid resuscitation. Get access quick. Current guidelines emphasize balanced transfusion strategies, often using that 1 to 1 to 1 ratio of plasma, platelets, and red blood cells over excessive crystalloids, like saline. The insight here is that excessive crystalloid fluids can actually dilute a patient's clotting factors, worsening their ability to stop bleeding and potentially leading to a dangerous cycle of continued hemorrhage. Too much saline is bad.
right, that dilution effect. And for diagnostic tools, we have the fast exam and CT scan, but they have distinctly different roles, right? You wouldn't use them interchangeably.
Precisely. Different tools for different situations. The FAST exam is a rapid bedside, non invasive ultrasound used to detect free fluid, typically blood, in the peritoneal, pericardial, and pleural spaces. Quick look for blood. It's excellent for quickly assessing unstable blunt trauma patients because it can be done right at the bedside without moving the patient. Crucial for instability. However, its limitations are significant. A negative FAST does not rule out serious abdominal injury, as it's not good for detecting retroperitoneal hemorrhage or hollow viscous injuries. It can miss things. So, the clinical pearl, it tells you if there's a lot of fluid, but not if there's a little or if it's in a hidden spot. It's a screening tool, not definitive. The CT scan, on the other hand, is the gold standard for stable patients, provides amazing detail. It provides incredibly detailed visualization of solid organs, vessels, retroperitoneal structures, and even hollow viscous perforations. Sees almost everything. But critically, it's contraindicated in unstable patients due to the risk of transporting them to the scanner and the delay it causes in definitive intervention. Can't take a crashing patient to CT.
So it's about using the right tool for the right patient based on their immediate stability. Makes sense. And what about non operative versus operative management? How does that decision impact nursing care? Sometimes they don't operate. Like,
It makes a huge difference in the care plan. Yes, many stable solid organ injuries, especially those affecting the spleen or liver, are now managed non operatively, meaning without surgery, watchful waiting, basically. The nursing role here is paramount. Meticulous serial abdominal exams, frequent vital signs monitoring, and trending hemoglobin and hematocrit levels to monitor for ongoing bleeding. Lots of close observation. If the patient shows any sign of deterioration and instability, worsening pain, or evidence of ongoing hemorrhage, urgent surgical intervention, a laparotomy is immediately needed. Things can change, so you need to be ready. A vital note is to keep abdominal trauma patients NPO, nothing by mouth until they're definitively cleared of surgical risk. Don't want them eating if they might need surgery soon. This is where the detective work meets the urgency of a ticking clock, with nurses constantly interpreting subtle clues and preparing for rapid action, knowing that a patient's condition can pivot in an instant.
So, once the immediate crisis of trauma is addressed, the fight for life isn't over. Not by a long shot, it sounds like. There's a long shadow of trauma with significant complications that can arise often days after the initial injury. What are some of these insidious secondary threats that nurses are watching for?
That's right. The initial save is just the first battle. Patients who survive the initial trauma are still at high risk for what we call secondary mortality from severe complications. Things like acute respiratory distress syndrome, ARDS, sepsis, and multi organ dysfunction syndrome, MODS. These are major contributors to post trauma morbidity and mortality and require intense, vigilant nursing care long after the ER. ARDS is a severe inflammatory lung condition that often develops within 24 to 72 hours post trauma. It can be triggered by direct lung injury, like a pulmonary contusion, or massive transfusions given during resuscitation, or even sepsis originating elsewhere. From a nursing perspective, they would see signs like rapid breathing, declining oxygen saturation despite high oxygen flow, and diffused crackles in the lungs on auscultation. The lungs sound wet and stiff. Nursing interventions involve managing oxygen, collaborating with respiratory therapists on lung protective ventilation strategies, like low tidal volume, and even special prone positioning, flipping the patient onto their stomach to improve oxygenation. The core insight here is that the initial trauma can cause a systemic inflammatory response that ends up severely damaging the lungs, turning them stiff and unable to effectively exchange oxygen. The body's own response harms the lungs.
So essentially, it's like the lungs get so inflamed and damaged that they just give up trying to exchange oxygen efficiently. They become waterlogged, almost.
That's a very good way to put it. Yeah, they become heavy, stiff, and filled with inflammatory fluid, losing their ability to function normally. And then there's sepsis, which sounds terrifying, especially after surviving an initial trauma. Infection taking over. It is, and it's huge concern, particularly after abdominal trauma with bowel injury. Sepsis is a life threatening organ dysfunction caused by the body's dysregulated response to an infection. The body overreacts. It commonly arises from hollow viscous injuries where gut contents leak, or from penetrating wounds that introduce bacteria. Early recognition is absolutely vital, often guided by the Sepsis 3 criteria and the quick SOFA score, which looks at changes in systolic blood pressure, respiratory rate, and mental status. Quick bedside check. Nurses are critical in immediately activating sepsis protocols, obtaining blood cultures to identify the infection, and initiating antibiotics within 1 hour of recognition. That 1 hour window is crucial. The clinical pearl here is stark. Every hour of delay in sepsis treatment significantly increases mortality. Time is tissue, time is life. They also manage aggressive fluid resuscitation and prepare vasopressors if blood pressure remains dangerously low despite fluids.
It really is a battle on multiple fronts then. The fight doesn't end when the immediate crisis passes. It transforms into a vigilant battle against these insidious secondary threats. And mods? That sounds even worse.
MODS, or multi organ dysfunction syndrome, is often the ultimate devastating consequence. It's where things really fall apart. It's the progressive failure of multiple organ systems, often stemming from prolonged uncontrolled shock, severe inflammation, or unchecked sepsis, a domino effect. Signs can include declining urine output from kidney failure, worsening hypoxemia from lung failure, rising lactate levels indicating poor perfusion, abnormal liver or kidney tests, along with neurological changes, multiple systems failing. Nurses are crucial in aggressive infection prevention, meticulous fluid and hemodynamic management to support organ function, and early escalation of care to try and prevent this devastating cascade. trying to stop the dominoes. For instance, a patient initially stabilized might develop a fever, rapid breathing, and declining oxygen days later. A prime example of these secondary complications unfolding, demanding constant vigilance and quick action.
It's clear that trauma care is not a solo act. It's a symphony of skill, as you said. Let's talk about the interdisciplinary trauma team roles. It seems like a truly orchestrated effort. Everyone has a job.
Absolutely. You cannot do this alone. Effective trauma care is the ultimate team sport. Nurses, surgeons, emergency physicians, respiratory therapists, pharmacists, technicians, social workers, countless others must work in seamless, often unspoken coordination. It's a true high performance team functioning under incredible pressure.
What's the nurse's role specifically within this intense environment? How do they act as that central hub you mentioned?
The nurse is the constant presence at the bedside. That's key. They are responsible for the initial stabilization, meticulously monitoring the patient's ABCs, airway, breathing, circulation, even as other team members perform their tasks. They anticipate and prepare for crucial interventions like chest tube insertions, blood transfusions, or intubation, getting everything ready before it's needed. Crucially, the nurse often serves as the communication hub, synthesizing countless observations, continuously updating the team on changes in the patient's condition, and relaying vital information to everyone from the charge nurse to the attending surgeon. They are the eyes, ears, and hands, ensuring no detail is missed in the chaos. The coordinator, really.
And the surgeons and emergency physicians, how do they lean on the nurse's observations in that fast paced setting?
They are the leaders in rapid diagnosis and operative planning, performing definitive interventions like laparotomies or thoracotomies. They make the big decisions and do the procedures. They lead the resuscitations, but their decisions are heavily reliant on the real time updates and meticulous preparation provided by the nurses. The surgeon isn't at the bedside constantly, especially during the initial stabilization. The nurses and that real time assessment is critical for decision making. They need that info.
Makes sense. And the respiratory therapist, what's their unique contribution to breathing management? Uh,
They are absolutely critical for all aspects of airway management, optimizing mechanical ventilation settings, ensuring effective oxygen delivery, and preventing ventilator associated complications like pneumonia. They own the ventilator. They are the specialist for everything related to breathing support, working hand in glove with the nurses and physicians. It's a beautifully choreographed effort. And to ensure this coordination is flawless, especially when handing off information, a structured communication tool called SBAR is commonly used: situation, background, assessment, recommendation.
SBAR. That sounds incredibly important for keeping everyone on the same page in such high stress situations like a shared language. Can you give us a real world example of how that works in action?
Sure, imagine a nurse in the trauma bay. The scene is controlled chaos, but their communication is crystal clear and structured. Situation: we have a 30-year-old male with blunt abdominal trauma, currently hypotensive. Clear, concise problem. Background: he was in a high speed MVC rollover with suspected splenic injury based on mechanism, relevant history. Assessment: he's tachycardic at 138 beats per minute. His skin is pale and cool. BP is 88 over 50, and the fast exam is positive for free fluid in the abdomen. Key findings. Recommendation: I recommend activating the massive transfusion protocol immediately, and we need an emergent surgical consult for laparotomy right now. Clear action needed. This structured, concise delivery of information is a life saving tool. It ensures nothing gets missed. It highlights the profound trust and coordination required in these environments, where language itself becomes a tool for survival, ensuring no critical piece of information is lost in the urgency.
These sound like such intense situations, but let's make it even more real with some case studies in action. Can you walk us through a vivid scenario of blunt thoracic trauma, perhaps from something like a motorcycle collision?
Certainly, picture this. A 28-year-old male arrives at the emergency department after a high speed motorcycle crash, helmeted but still high impact. He's in severe respiratory distress, gasping for breath, and his oxygen saturation is dangerously low at 84%, even with supplemental oxygen via non rebreather mask. When the nurse quickly assesses his chest, they find absent breath sounds on the right side, distended neck veins bulging out, and worryingly, his trachea feels like it's shifted slightly to the left side. Heart rate is racing at 152 beats per minute. BP is plummeting 80 over 50.
That immediately sounds like a textbook case of a tension pneumothorax, doesn't it? The physical signs are so dramatic: absent breath sounds, jugular venous distension, tracheal shift, shock.
They are classic signs, and the nursing actions here would be immediate and decisive, simultaneously ensuring high flow oxygen, alerting the provider immediately about the suspected tension pneumo, grabbing the needle decompression kit, assisting the provider with that procedure to release the trapped air right now, and quickly preparing the chest tube insertion tray for definitive management once the immediate pressure is off. At the same time, someone else is establishing 2 large bore IVs, and O negative blood would be ordered and brought to the bedside, ready for transfusion, as time is of the essence for this patient. Continuous, meticulous monitoring of vital signs and oxygenation would be maintained throughout every step. Every second matters. The urgency of recognizing and intervening in this immediate life threat is paramount. Post stabilization, the team would then remain vigilant for anticipated complications like recurrent pneumothorax infection or ARDS. This case perfectly demonstrates how rapidly a patient can deteriorate and how a nurse's ability to identify those key signs leads to immediate life saving actions.
That paints such a clear picture of the sheer speed and diagnostic acumen required. Now let's consider a scenario for penetrating abdominal trauma, say a stab wound.
Right.
How does that unfold differently?
Okay, for this, imagine a different 28-year-old male. This one has sustained a stab wound to the lower left abdomen. He arrives awake, but distressed. Upon arrival, he's clearly in shock, hypotensive at a dangerously low 70 over 46, tachycardic at 150 beats per minute, diaphoretic, clammy, and sweating profusely, and his abdomen is rigid with rebound tenderness when touched, indicating peritonitis. A quick, fast exam at the bedside shows free fluid, confirming significant internal bleeding. Here, the nursing actions are again rapid and multifaceted, but the focus shifts slightly. Their immediate priority is airway, preparing for potential intubation because shock can compromise breathing, then establishing those 2 large bore IVs for massive fluid and blood resuscitation, immediately activating the massive transfusion protocol, getting blood products flowing fast, and communicating via SBAR for an emergent laparotomy. This patient needs surgery now.
So, in this case, surgery is the immediate life saving next step. No waiting around.
Precisely. There's no non operative option here. The patient is bleeding significantly internally, likely has a bowel injury too, given the peritonitis, and surgery is the only way to stop the bleeding and repair the damage. Postoperatively, the vigilance then shifts to complications like sepsis from that likely hollow viscous injury, or MODS from the prolonged hypotension and massive fluid shifts he endured. The recovery is just beginning. This case highlights the need for rapid surgical preparation and aggressive fluid and blood resuscitation for an unstable, penetrating trauma, where every minute literally counts towards survival and preventing further organ damage. Get them to the OR fast. These stories aren't just hypotheticals. They represent the daily challenges nurses face and often overcome with their incredible skills and teamwork.
It's astonishing to hear the speed and complexity involved. Really mind blowing. But beyond the clinical, trauma care also brings up profound ethical considerations in the fast lane. When you're making some rapid decisions under so much pressure, how do those ethical dilemmas come into play?
Yes, it absolutely does. The speed doesn't negate the ethics. Sometimes it intensifies them. Trauma care often involves complex ethical dilemmas, and nurses are frequently at the forefront of navigating them. For instance, in mass casualty events, decisions about resource allocation become agonizingly real. Who receives the last ventilator, the last unit of blood? Who receives immediate care, and who might have to wait based on their prognosis and chance of survival? Awful choices. Or balancing aggressive, high intensity interventions with a patient's grim prognosis, especially when survival might mean a severely diminished quality of life that the patient might not have wanted. Nurses are often the patient's strongest advocate in these moments, ensuring their dignity is preserved even amidst high intensity resuscitation efforts, making sure they're treated as a person, not just an injury. They also facilitate crucial, empathetic communication with families, often delivering difficult news or explaining complex situations under immense stress. They constantly balance patient advocacy with strict team protocols and resource limitations, ensuring that comfort measures are not overlooked in the urgency of saving a life. It's a heavy, heavy responsibility.
That's a lot for anyone, let alone a whole team, to carry day in and day out. The emotional weight must be immense. How do teams process all of this and continue to learn without burning out?
That's where the power of debriefing comes in. It's so important. Structured debriefing after major trauma resuscitations or even difficult cases is absolutely essential. It provides a critical, non judgmental opportunity for the entire team, nurses, doctors, techs, everyone involved, to review what went well, what could have been done better, and crucially, to process the often difficult and emotionally charged cases, talking it through. This helps reduce burnout, address moral distress, and build moral resilience within the team, enabling them to continue performing under immense pressure day after day. This commitment to continuous learning and improvement, to looking critically at your own performance as a team, directly translates to better patient safety and outcomes down the line. The core insight here is that even in the most critical, fast paced fields, learning is continuous, and humility in evaluating performance, admitting mistakes, or near misses is a sign of immense strength and professionalism, not weakness.
What an incredible journey into the intense, life saving world of trauma care we've taken today.
We've truly covered so much ground, haven't we? From the foundational ABCs and understanding the intricate anatomy of the chest and abdomen to the specific tailored nursing interventions for different injury types, blunt penetrating, we've seen how they anticipate life threatening complications like ARDS or sepsis, and the undeniable power of a coordinated, highly communicative trauma team using tools like SBAR. It truly reinforces the nurse's pivotal role as the vigilant eyes and hands at the bedside, ensuring timely evidence based care when every single second counts. They're indispensable.
It really hammers home how a few seconds can change everything in trauma care. Absolutely everything.
Yes, it does. And
And how the hidden aspects of that vigilant reassessment for those subtle clues or that structured S-bar communication, ensuring everyone's on the same page, are often the most life-saving, maybe even more so than the dramatic visible procedures we might imagine. It makes you realize how much precision and constant vigilance is at play even when we can't see it from the outside.
it absolutely does. And this kind of systematic thinking, this rapid response capability, and this transparent teamwork, it isn't just confined to the trauma bay, is it? It makes you wonder what other professions or even daily situations might benefit enormously from this level of organized, high stakes coordination, clear communication, and the continuous learning and debriefing we see in trauma teams, even when the immediate stakes aren't quite so stark, maybe.
That's a great provocative thought to leave you with. Think about that. Where else could these principles apply? Reflect on the immense responsibility and expertise demonstrated by nurses and the entire trauma team in these critical fields. Their dedication truly is life-saving and often quite literally beyond what many of us can imagine. Thanks for being with us today on The Confident Nurse. Don't let license renewal sneak up on you. Get your accredited CE courses, printable study guides, and quick quizzes to lock it in. Download certificates instantly, finish your hours, feel confident, and get back to life. ConfidentNurse.com